Now, look at Extract 1. Extract 1, questions 31 to 36. You hear the discussion between a senior doctor and junior doctors on epidermal nevi. You have 90 seconds to read questions 31 to 36.
Hello, doctor. Can you please explain different types of epidermal nevi?
Epidermal nevi are categorized based on their clinical features, by the site of occurrence and their extent of spread. However, mostly they are categorized based on the epidermal cell that predominates in the lesion. In certain patients, multiple epidermal nevi occur along with systemic abnormalities, and they form the epidermal nevus syndromes. Based on the occurrence patterns, epidermal nevi are categorized differently despite the similarity in their microscopic appearance. Nevus varicosus occurs as a single or multiple lesions, but always localized. Nevus urineus laterus occurs as a linear pattern of lesions. Ichthyosis hystrix are generalized lesions. However, epidermal nevi are also classified by their cell of origin. Nevus sebaceous are quite common and are made up of sebaceous glands with or without hair follicles. They're found commonly on the scalp, but also on the extremities or trunk, and are pale yellow in color, with a smooth, hairless surface. They are present in infants, though they may manifest only after puberty or in childhood. 1/4 of the cases eventually give rise to tumors and are mostly benign. Often it is connected with the occurrence of Schimmelpenning syndrome, phacomatosis, pigmentokeratotica, didymos-aplastic sebacea, and scalp syndrome. Keratinocytic epidermal nevus are also called non-organite epidermal nevi and are quite common among this group of lesions. They follow the lines of Blaschko and begin as brownish macules, thicken and darken with age to become plaques. They may be defined as linear or varicose based on their appearance. Other variants include the epidermolytic epidermal nevus, the acantholytic epidermal nevus, and the systemized epidermal nevus. Nevus comedonicus are formed of proliferated dilated keratinized follicles, often inflamed or showing signs of infection as a result of blockage, forming blackheads, and pitting is often seen. It may be associated with brain abnormalities, bone defects, and cataracts. The Angora hair nevus is remarkable for the long and soft white hair, like Angora wool, that grows from it. It may be associated with other defects of the brain and bones. The Becker nevus is a dark patch of hairy skin that appears like a checkerboard shape, becoming larger and darker after puberty due to androgen-dependent nature. Often it is found on the upper part of the back or on the shoulders. It is linked with other skeletal-muscular defects, forming the Becker-Nevis syndrome. Inflammatory linear varicose epidermal nevus is linear and forms plaques, usually unilateral. They are usually pruritic and appear inflamed and hyperkeratotic. The first appearance is after 6 months of age. Porokeratotic eccrine nevus appears as warty keratotic papular lesions, mostly on the palms and soles, but in some cases they may appear all over the skin. Now, look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of gangrene. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Can you explain different types of gangrene?
Well, the term gangrene refers to the death of tissues due to lack of blood supply and deeper invasion of infected tissues, which are broadly classified into two categories, dry and wet gangrene. Although there are many types of gangrene, all types of gangrene manifest either as dry or wet form. In the dry gangrene, there is obstruction or slowing of blood flow into the organ or part of the body that is affected. Peripheral parts like toes, fingers, nose tip, earlobes, etc. are commonly involved. Often, dry gangrene is seen in patients of type 1 and type 2 diabetes, where long-term high blood sugar damages the small arteries and blood vessels that supply blood to the end parts of the body, such as fingers and toes, resulting in obstruction and slowing of blood flow and ultimately gangrene. In patients with dyslipidemia or high cholesterol, there is a risk of cholesterol deposition and lipids called plaques within the blood vessels. In the peripheries, such as fingers and toes, this leads to decrease in the blood vessel diameters by narrowing of the lumen, resulting in formation of gangrene. Patients with peripheral arterial disease develop fatty acid deposits or develop narrowing of peripheral blood vessels. Certain conditions include scleroderma and Raynaud's disease, where the blood supply is restricted to leg or hand muscles, resulting in gangrene. Dry gangrene is usually identified by cold, painless, and dry and shriveled up affected part. However, there will be healthy skin surrounding them. The area affected appear mummified. Wet gangrene occurs due to infection and invasion of bacteria into deeper tissues after injuries, foot ulcers, frostbites, or burns. There is excessive swelling of the affected part due to release of the toxins from the invading bacteria, resulting in blockage of the blood supply and worsening of the infection as the white blood cells cannot reach the area affected via blood vessels. Wet gangrene spreads much quicker than dry gangrene and may result in life-threatening complications like septic shock. Wet gangrene appears discolored or black, and often with acute and excruciating pain. There are black blisters and foul-smelling pus beneath the thinned skin at the area. Since the infection is associated with discharge of pus, it is called wet gangrene. Gas gangrene is caused by bacteria called Clostridium that is found in spores present in the soil. Gas gangrene was a common cause of death in the wars. The gangrene is caused by the toxins released by the bacteria. Gas gangrene is further categorized into three types: traumatic gas gangrene, occurring after injury; non-traumatic gas gangrene; recurrent gas gangrene, caused by C. perfringens species of bacteria. Necrotizing fasciitis is a deep tissue infection caused by bacteria like Staphylococcus or Streptococcus. The bacteria spreads deep into the skin and into the tissues and attacks the soft tissue and the fascia, which is a sheath of tissue covering the muscle. This can occur in an extremity following a minor trauma or due to the opportunity for the bacteria to enter the body, such as surgery. The necrotizing fasciitis infection, known as flesh-eating bacteria, is most common with minor trauma. A mixed bacterial infection is often the cause after surgery. Internal gangrene is caused when blood supply to an internal organ is hampered, usually by pressure from another organ or growth. For instance, in hernia, there is an abdominal opening where the intestine may get blocked, and the blocked area turns gangrenous. Noma or cancrum oris affects the face. Fournier's gangrene is a rare but life-threatening condition affecting the penis and genitalia. This disease has been shown to have a predilection for patients with diabetes as well as long-term alcohol misuse. However, the disease can also affect patients with non-obvious immune compromise. The development and progression of the Fournier's gangrene is often fulminating and can quickly cause multiple organ failure and mortality. Due to such potential complications, it is crucial to diagnose the disease process as early as possible. Death rate is very high despite antibiotics and aggressive debridement and broadly accepted as the standard treatment. Mullany's synergistic gangrene is a rare type seen in patients after surgery. Mullany's synergistic gangrene is caused by S. aureus and Streptococcus organisms. One of the recognizable symptoms is the presence of extremely painful lesions that usually form in the second week after surgery or minor trauma.